Hello everyone, in this video we discuss about the transfusion reaction. To prevent these transfusion reaction, we need to carry out certain tests like cross match, minor and major cross match, and check the proper detail of the patient and the blood unit we are going to transfuse. So 2 to 4% of cases of blood transfusion shows these transfusion reactions. They are the unfavorable complication of transfusion, broadly divided into non-infectious and infectious transfusion reactions. Examples of infectious transfusion reactions are transmission of HIV through the blood transfusion or transfusion of the blood product or blood components, hepatitis B and C, cytomegalovirus, malaria and syphilis. In non-infectious transfusion reaction, they broadly divided into immunological transfusion reaction and non-immunological transfusion reaction. So in immunological transfusion reaction, there are two types of transfusion reaction. One is immediate and second is delayed. In immediate immunological transfusion reaction, there is hemolytic transfusion reaction, which is seen in ABO and RH incompatibility, febrile non-hemolytic transfusion reaction, allergic transfusion reaction, in which in rare cases there may be anaphylactic shock, and transfusion related acute lung injury. In delayed immunological transfusion reaction, there is alloimmunization or hemolytic transfusion reaction can also seen in the delayed immunological transfusion reaction, and transfusion associated graft versus host disease. In non-immunological transfusion reactions, immediates are circulatory overload due to blood transfusion, air embolism, which is seen in the past when we used glass bottles for the transfusion. In delayed non-immunological transfusion reaction, iron overload can be seen at thrombophlebitis at the site of the vein puncture. Now we will see these transfusion reaction in little detail. In non-infectious transfusion reaction, as we have discussed, immunological and non-immunological transfusion reactions are there, in which acute hemolytic transfusion reaction in immunological transfusion reaction, the most common is ABO incompatibility, which is due to the result of ABO incompatible blood transfuse. This may be result due to the clerical error and wrong labeling of the cross-match sample. The clinical feature seen in this kind of transfusion reaction is fever, chills, pain in lumbar region, dyspnea, tachycardia and hypotension. This predominantly result into the intravascular hemolysis, which can be detected by hemoglobinuria, oliguria, and may result into acute renal failure and in some cases disseminated intravascular coagulation. How to treat this kind of transfusion reaction? First is immediately interruption of the transfusion, and then we give some steroids for immunosuppression. The other immediate kind of immunological transfusion reaction is RH incompatibility. Hemolytic transfusion reaction can be delayed type, which is seen in the recipient, in which AB antibody titer is too low at the time of the cross match, so there will be no immediate reaction. Then the gradual increase in the antibody titer is occur and result into the gradual lysis of the donor cell. These are mainly HLA antibodies, result into the mild and extravascular hemolysis, usually seen after 4 to 14 days of the transfusion, presented as unexplained anemia and jaundice. Febrile non-hemolytic transfusion reactions. They can be seen after 30 to 60 minutes of transfusion, presented as fever, chills, rigor and headache. The main causative reason is sensitization of leukocyte antigen in the febrile non-hemolytic reaction. Some allergic reaction can also seen in transfusion. The mechanism behind this is allergens on the donor plasma react with the IgE on the recipient plasma and activate the mast cell. Then they release some mediators like histamine and leukotrienes, result into the urticaria, fever, bronchospasm, and in some cases anaphylactic shock. TRALI, also known as transfusion related acute lung injury. The mechanism behind developing TRALI is in donor plasma there are anti-HLA antibody. They binds with the recipient leukocyte and result into the aggregation of leukocytes in pulmonary vasculature, and then they release some mediators resulting into the increased pulmonary capillary permeability and ultimately acute respiratory distress. TRALI can occur during the transfusion or within the 6 hours of transfusion, presented with the fever, cough and shortness of the breath. On chest X-ray, typically bilateral interstitial infiltrate are seen. Another immunological transfusion reactions are transfusion associated graft versus host disease. This is a rare phenomena, can be fatal and seen after 10 to 12 days of the transfusion. So this is a delayed type of immunological transfusion reaction. Mechanism behind the TA-GVHD is mature T cell in donor blood component attacks the recipient tissue, particularly in immunocompromised host, presented with the fever, skin rash, diarrhea, jaundice and bone marrow failure may result into the pancytopenia. This transfusion associated graft versus host disease can be prevented by the transfusion of irradiated blood component, particularly in the immunocompromised recipient. The other category of transfusion reaction is non-immunological transfusion reaction, in which circulatory overload can be seen when we transfuse the whole blood. This is an immediate type of reaction. Air embolism, earlier when the glass bottle used, this is a very frequent phenomena. Now we use closed tubing system, so air embolism is very rare these days. Iron overload or transfusion siderosis is a delayed type of non-immunological transfusion reaction. When a person receives multiple transfusion over a period of few years, like in thalassemia, iron gets deposited in reticular endothelial cells of the spleen, bone marrow, liver, heart and endocrine glands and result into the decreased functioning of these systems. Thrombophlebitis at the site of the venipuncture may also seen. Now there is a condition which is known as massive blood transfusion. So first we need to understand what is the definition or criteria of massive blood transfusion. So there are so many definitions. First is more than 10 unit of PRBC in 24 hours. Transfusion of more than 10 PRBC in 24 hours, or more than 4 units of PRBC in 1 hour, or the replacement of 50% of blood volume within 3 hours, or 100% of blood volume replacement in 24 hours. These are the definition of massive blood transfusion, and the one term is known as ultra massive transfusion. which is defined as more than 20 units of PRBC transfused within 48 hours. What are the complications of massive blood transfusion? First is coagulopathy due to the dilution, platelet and coagulation factor decrease. Metabolic derangements like hypocalcemia because of the chelation of calcium by citrate, hyperkalemia because due to the rapid infusion of blood there will be lysis of the RBC result into the hyperkalemia, which may result into the arrhythmia sometimes. Acidosis, initially from the shock there can be acidosis, and later on citrate convert into the bicarbonate may result into the alkalosis. Hypothermia due to the transfusion of the cold blood component, TRALI, and transfusion associated circulatory overload. So these are the complications seen in massive blood transfusion. Thank you very much.